trust. So they are certainly an amazing source of funding, but I think importantly, they are really thoughtful about how they do their funding, and we hope to partner with them in the future. And there are a few others that I pop up here just because they're focused so specifically on NCDs. Communities for Healthy Hearts is a Novartis initiative. Healthy Heart Africa is an AstraZeneca initiative. And I bring that up because research is coming from all sectors. It's not just from the academia, it's not just funded by government, but the private sector are also involved. And that brings both resources and challenges. And I think, it's something that we talk about all the time within the context of GACD, that it's not so that, I don't think it's true that because we have potential conflicts with the private sector, we shouldn't engage with the private sector at all. I think what that does, though, is it invites us to have a conversation about how to deal with these conflicts. And it's something that as you become more fluent in the language of research, it's something that I think all of you need to think about, and your thoughts on engagement with the private sector. These are just a snapshot of the funding agencies involved within GACD, and I'm not going to talk you through the entire list, but I think what's important to show is that as we develop a stronger scientific priority and research agenda on NCDs, countries are coming to the table. More and more countries are coming to the table. When we started with GACD, we had 4 countries, and today we have 14. It's one of the reasons that I'm here. It's one of the reasons that James Hospitals and I have had this ongoing conversation, is that not only do I see that there's a lot of capacity in this part of the world, albeit varied from country to country, and not only is there need in this part of the world, but there's a huge gap in knowledge and data and evidence that I think we can help to figure out how to address. This is just a slide telling you a little bit about what we do at GACD and how we've done. I would say all indicators are good. So one indicator is how many funders we have at the table. As I said, we've got 14. This is also telling you that the amount of funding that we've gotten into each call year on year has increased. We started with $22 million in our first round of funding with hypertension, and the last round of funding for mental health was a $72 million round. Our current call open today is a call on scale-up of hypertension and diabetes interventions. So we are trying to increase the amount of funding and broaden the scope of this funding as we go along. And one thing also to consider as you are embarking or going along in your research career is the notion of equity and inequity in research. So one of the things that we are trying to do is to strengthen capacity in implementation science, and with a focus on women and researchers in low and middle income countries. So we have seen that throughout our workshops, we have more women by 2 to 1. And the vast majority of our participants, 87% of our participants, come from low and middle income countries. And that's something that we'd love to bring to this part of the world. It's really important for us that research is not just done by Americans and Brits and Australians, and then they sort of come here for a few months and then go home and write up their PhDs. It's really important that the researchers from these communities where the research is happening are active participants and are co-PIs and are shaping the research agenda and not just responding. There are challenges and opportunities in scaling up, and this is a list of them, but what I thought I'd do is just talk you through some of the thoughts that we've had in the context of GACD. So in terms of regulation and policies, I mean, what I found really fascinating the last couple of weeks was there was a report that was issued by Bloomberg, and it focused on the various interventions that countries could take. And what was left off of that report was taxation of sugary sweetened beverages. And there was an event in Geneva, and one of the ministers of health said, why is that not on there? Why is taxation of sugar sweetened beverages not on there? And the answer was because it's not a Best Buy. And this minister said, we need you to put it on there. We need it. We need this to make our case back to our governments in terms of why we need to advocate for this taxation. And so I think as we think about prioritization, we also need to think about the specific needs in each country. And that may vary from place to place, and that's something to think about in the diversity of countries that you have here in the Caribbean. Partnership framework, I'll get into that in a second in a few other slides. And relationship development. This is something that I think is really, really important in the context of research. Today, in the funding environment for research, funders are increasingly and almost exclusively funding research collaborations. So it's increasingly rare to see funding on global health with funding for a single team from a single institution. They are funding collaborations, and so relationship development that may not be immediately translatable to a proposal is actually really important to cultivate, so that when calls for research funding come out, you are ready with your partnership. And I think that this notion of amplifying your voice is also really critical, but I will skip that because I've got 1 minute left. So where is research happening? It's happening all over the world, but sadly, not a lot of research in terms of funded projects from global entities is happening here, and we'd love to see more of that. And I'm going to wrap up. Oh, yes. Last thing, there is not a lot of evidence. There's a huge gap in terms of the application of Best Buys in these parts of the world. So I would strongly urge you to think about how you could fill those gaps. And back. I promise I'm going to wrap up. Who is paying attention? You can ask me more about this slide during the breaks, but it's really important that you know that increasingly we are getting calls from the World Bank, from responsible investors, and from folks focusing on research fairness. These are issues that are happening sort of in the global health research community. And what can you do today? This is your list here. Make friends for the long term. Stay up to date. Social media is really important. Strive to be evidence-based and rigorous, and look for gaps and fill them. Really, really critical. So everyone repeat this with me. Ready? In God we trust, all others bring data. She'd be very proud. Thank you.
Thank you, Ms. Gore, for a very insightful presentation. I like the quote, in God we trust, all others bring data. Can I add, all others bring funding to that as well? Anyway. The floor is now open for questions based on the presentation. Any questions from the audience?
Good morning, Virginia Asin from the Caribbean Public Health Agency. Not so much questions as comments. Two comments. One is based on your slides on inequity in research, and you realize that in the Caribbean you find yourself in a catch-22 because we, as you rightfully mentioned, we are in a region that is very interesting for research, and yet there is not sufficient data that is of high quality that can be used for research. So the interest in scientists for our data is not as well as you would wish it would be. And we realize that we find ourselves in a serious resource gap. And the resource gap, and I'm glad that the chair rightfully mentioned, can we add funding? Because the research gap is in human resources. Having sufficient, well-trained, highly trained persons to be able to do research in our region, and not only in educational institutions, but also in public health institutions such as CARPHA. And at the same time, funding resources to be able to carry out the research. So that is my first comment, and of course, I hope that with these conferences, these discussions, the attention comes more to our region to make it interesting for researchers to start with the precursor phase to prepare us to be able to deliver quality data, therefore making it interesting. So the investment is not only in doing the research, but in preparing us to be able to do the research. And I'm glad that you mentioned, and I have put it also as a note, because we do have sufficient elements in our region to be able to advocate. And I hope that when you put up this slide with all the stakeholders, that the next time we will see on top of it also the logo of HCC as one of the serious civil society, regional civil society organizations that really do a very good job and was very instrumental in getting us on the agenda at the high-level UN meeting. And you also rightfully mentioned defeat NCDs, and everybody has high hopes for defeat NCDs, not to be the only one, but to set the stage for others also to follow. The second comment is more a pet peeve that I've had for years. I think it is important that we start using our information and our data to convince educational institutions to overhaul our educational institutions, because starting from kindergarten up to tertiary level and postgraduate, we continue to do our work in the same traditional way. Although we introduce maybe courses, maybe we put a little bit more stress on certain subjects, our whole educational institution needs an overhaul when it comes to being able to address NCDs in an adequate way. I think the last thing I want to say is that maybe it's time for us to also start thinking about creating innovative new vocations. We know that there is an implementation gap. We know there is a competencies gap that don't fit in our traditional nurses and physicians. And so we need to be innovative and start creating some of those new vocations that will fit our competencies gap that is existing. Thank you.
Thank you.
Yeah, just to respond quickly to the comments about funding. Within the context of GACD, we have funders who fund research at $100,000 level and then 20 million euro level. And so we are quite neutral in terms of how much investment you need to make to be part of GACD. And if anything, we've seen that those who are funding at the lower levels are attracting investments into their country. So I think that's to say that our model is you kind of have to put a little in to get something, to get a lot out. And that's what we've seen for a number of regions out there, like South Africa, like Mexico, your neighbors, Brazil, Argentina. These are countries that are part of GACD.
Thank you. Next.
Hi, good morning. Miriam Alvarado. Thank you so much for your presentation. I was wondering if you could speak a little bit about funding for NCD prevention in particular as distinct for treatment. I know you mentioned Bloomberg philanthropy and SSB taxes, but if you could share your insight more broadly, that would be wonderful. And I'm also curious what you think about funding for interventions that fall outside of the traditional public health sphere. So I'm thinking of things like trade tariffs or the built environment, and what is the kind of strategic funding landscape around those kind of interventions? Thank you.
Thanks for your question. I guess it's to remind folks that this is a health research conference, and the traditional funders of health research are mostly operating on a biomedical model. That's true for the NIH, that's true for the MRC. I mean, it says Medical Research Council. So where we started was funding disease-specific research, and that's what you saw in the last 5-6 years of GACD. Where we are headed is away from that. So it's a really great question for me to be able to introduce the idea that the next several rounds of funding calls, the next strategic plan for GACD is going to focus on cross-cutting issues. A good example might be an NCD prevention call. So what we are trying to do is signal to the research funding community that it's time to leave the disease-specific silos of research funding and move more towards cross-cutting issues. There might be another call on childhood obesity. There might be a call on multiple morbidities, and maybe one on regulation, which, as you suggested, is a topic that really needs addressing. We also find differences in countries. So Canada loves prevention. So they will emphasize prevention on all of their research funding calls with us, as opposed to some other funders that will focus on some other priority within the context, within that basket of research. But the research community has been heard on the funding side, and they are moving more towards, as uncomfortable as it is for them, they are moving away from disease-specific research.
Thank you. Thanks.
Good morning. Thank you for that very beautiful presentation, touching not just on burden, but also looking at the intervention side of things. So I wanted, you just mentioned it in a quick statement, so I wanted you to expand a little bit more on the conflicts of interest you talk with private sector, and how persons are reluctant to partner with private sector. There are those who think that we should partner with private sector in terms of thinking about insurance companies or banks, but are a little bit more reluctant when it comes to the food and beverage industry. So I just wanted you to just kind of talk about where you were along the spectrum.
Yeah.
No partnership at all, or just insurance companies, or food and beverage, and if food and beverage, to what extent?
Yeah. Thank you for that. I mean, it's a really, for me, it's a very important question as somebody who's worked in the private sector, who's worked in academia, worked for the UN. It's important to realize that at the end of the day, no matter who you work for, we have some overlapping goals. And it's really trying to find where those goals overlap. That's the work of partnership. There are going to be clear issues that are no-go zones. Right? There are going to be clear things that, if a pharmaceutical company wants to do research in Africa because they want to enlarge their market, and that's the sole purpose, then that's not the kind of research that we would necessarily want to partner on. But if they are looking to make sure that those who are undiagnosed, who have hypertension and that are undiagnosed, get diagnosed, that's some research that we would love to partner with them on, even though we know that a side benefit would be that their drugs will be taken up, right? Because somebody needs statins, et cetera. So I think what's needed is really sort of a convention on partnership with the private sector, or some meaningful way to assess whether or not this partnership is A, equitable, B, transparent, C, sort of driving towards the common goal of improving the health outcomes for the population. So that's not a clear answer, but it's to say that we all need to have confidence in that kind of dealing with these conflicts, rather than completely sort of deciding that that's not possible. Now, having said that, I think we can all agree that working with the tobacco company, working with the tobacco industry is just a no-go zone. And yet food is really challenging because we all need to eat. I mean, that's just the reality.
Thank you.
Good morning.
Good morning.
Thank you for your presentation, and particularly the emphasis on equitable distribution of power and decision-making in the region. I'm Dr. Richardson from the University of Virginia and have partnered with the Ministry of Health here for a number of years. I'm wondering about the availability of funding for gearing up for a significant research project, because as was noted, there's the issue of building local capacity. So I wonder if you could speak to those sorts of funding sources.
Yeah. it's a really important point that I have brought to my board. It's something that, if we are just funding at the point where these partnerships are ready to go, then we are going to be funding very few research collaborations. So we need to be thinking about how to enable these collaborations to happen. And one of the ways that I try to sneak it in, the back door, is that we run the GACD Research Network, and those are of researchers that are funded through GACD. But those guys have long arms, and they are part of big communities. So we're quite an open church, as they say. And if you have some kind of connection to a GACD researcher, you are invited to participate in all the various activities of GACD, which includes a potential to develop collaborations for future rounds of funding. And we've in fact seen that happen, where folks who are not previously part of the GACD Research Network are connected because they've got a piece of work with somebody who is, and then they get sort of roped into writing a proposal and being part of a new collaboration. So I think, I'm not saying the GACD is the only thing out there, but I would look for those opportunities. And sometimes, it's like internships, right? You're kind of stuck. Like you need to get the experience, but how can you get the experience if you don't get paid? It's sort of this bad cycle of trying to get on the wagon, as they say. But what we are hoping to do is develop a bigger sort of activity priority around the development or the facilitation of collaborations to prepare you for the calls that the funding rounds that we do put out.
All right, thank you. No other question. I have one last question from myself. Do you think that the case has been made or is being made through research and data as it relates to the economic impact of NCDs on personal, corporate, and sovereign wealth, and also translated in a manner that politicians and ministers of finance could understand and buy in?
I can answer that question with a question.
Mm-hmm.
Have we been successful in the NCD community, as successful in the NCD community as the HIV community has been?
No, we have not.
No. The HIV, I think as somebody, how many of you worked in HIV and now are working in NCDs? Okay. As somebody who also has gone that way, one thing that I think we need to do better in the NCD world is look at previous successes in public health, and I would argue that HIV is a success on the global scale. That includes making the case, for example, that HIV is a security issue, which is what put it on the global stage at the UN and what made heads of state pay attention. There were really angry people with HIV, really angry people that caught a lot of attention and made a lot of noise. And that also fueled the increases in levels of funding. So we're not angry enough.
So HIV had a face.
HIV had a face, a voice.
NCD doesn't.
And exactly.
Okay, thank you. All right, thank you very much. Let's give a round of applause for our presenter. We will now have move into a panel discussion on sustainable health systems for economic growth, development, and wealth. Sitting as part of that panel is Ms. Gore, Selena Gore, James Hospitalis, Dr. Hazel Laws, and Professor Carl Theodore from University of the West Indies Health Economics Unit. I think most of the persons here, we recognize who they are. James Hospitalis is the director of CARPHA. Ms. Gore, who just presented, need no further introductions. Dr. Hazel Laws is currently the Chief Medical Officer for St. Kitts, Federation of St. Kitts and Nevis. And Professor Carl Theodore is head of the Health Economics Unit of the University of the West Indies. So we have a very high-powered panel here. to discuss this issue of sustainable health systems for economic growth, development, and wealth. And I guess they are all coming from the individual perspective, looking at public health and research, looking at the disease profile and the health impact on the health system's impact on NCDs and other diseases of priority diseases, and the economics of it all through the HEU. James, you want to start the ball rolling?
Thank you, Rufus. You were our most delightful host to this conference 2 years ago, those of you who attended in the Turks and Caicos Islands. Good morning, everyone. As you know, we start this conference straight on. We have an opening ceremony later this evening, at which we hope the Prime Minister will be speaking. So I'm asked to comment for a few minutes and as we have a discussion on this issue of NCDs. And I want to look at just what Selena was saying, in God we trust, all others bring data. I like it. Actually, I hadn't heard that before. So you learn something all the time. And we have a conference that's themed around strong health systems for growth, for economic development, and for wealth. What does a doctor have to say about that? What could I know about that? And when Selena presented the data, she showed things like, well, Africa is mostly still HIV/AIDS. And I would a little challenge you that it depends on how you present the data, because their standardized mortality ratios for cardiovascular are off the charts. Proportionately, they still have a big problem with infectious, but relatively, they have a huge problem with NCDs. And I was in Haiti recently. Anybody here from Haiti? Bonjour. And we were looking at how you achieve in a poor country coverage for NCDs, certainly secondary prevention as well as primary prevention. And your map showed HIV. That's what Haiti is worried about. Data changes over time. The big Haitian NGO, GESCIO, presented data on 50 or 60,000 people with HIV. Well, they don't die from AIDS anymore. Once you're on antiretrovirals, you die from NCDs. And hypertension and diabetes and hyperlipidemia are the problems, and amputations and kidney failure and blindness, just like the regular population. Estimated 2 million people with hypertension in Haiti, maybe half have been diagnosed, and 300,000 with diabetes. But no advisor in the WHO office who's responsible for NCDs. And in any country of the world, if there's no WHO person who has disease X on their name tag, disease X tends not to be a priority. So the data does change over time, and as it emerges, you realize, hang on a minute, there's a really serious problem of NCDs in poor people. And in Haiti again, which a lot of folks are living on less than $2 a day, and that's more than half of the whole of the CARICOM community. How do you achieve treatment for hypertension even with cheap drugs? And two things struck us. You definitely need your money, because the people of folks are poor, and you need a whole new model in which the care and the prevention is going to be in the community. So bringing that data means we've got to tie together not only our health metrics, but metrics that are going to speak to other people. Years ago, I used to work on hotel and tourism and foodborne disease in the industry, and I went to a Caribbean Hotel Association board of directors, very big egos, mostly male at that time, and talked to them about foodborne disease in the industry, and they almost ran me out of the town. A year or two afterwards, I learned, and I went and talked about improving profitability through attention to health and hygiene and all these other things. And people came up afterwards and said, oh, where do I sign up? 95% of what I had said was the same thing. It's just the frame was reframed. So how do we reframe this in terms of the economy and wealth? And what is the evidence that, where's the data that this should matter to ministers of finance? Well, last year in November, I had a meet. Anybody here from JA? Must be more Jamaicans in the audience. Thank you, sir. Minister Shaw, Minister of Finance, I hadn't met him before. He said, who are you? What do you do for Jamaica? Oh, that's okay. You just go on the back foot. When you bring the data, I had it. Here's what we do for you. Here's the estimated return on investment. And he nodded. And then I made a pitch for something that I will highlight in my remarks. we're pushing for a meeting, a high-level meeting on the economic dimensions of NCDs early next year. And we have CDB, Caribbean Development Bank, on board, and the World Diabetes Foundation on board. World Diabetes Foundation, don't they fund clinical stuff? They're evolving, they're going upstream. They're funding obesity prevention, and now they're funding economic dimensions issues, because you've got to get to the finance and planning and development folk for this whole of economy approach. And Minister Shaw last year, within minutes, said, that is overdue, what you're talking about. 2 weeks ago, I met the new finance minister of Jamaica, Nigel Clark. He said, who are you? What have you done for me lately? Because he's new. So you bring the data, here's what we've done for you lately. And we build a relationship. Selena said something very important about building relationships between ourselves and researchers and other partners elsewhere, because the research funding is for consortia, and without those relationships, we're not going to get the funding. So it is a prerequisite, and something I specialize in, building relationships and partnerships. But Nigel Clark said, you know, now I'm in electoral politics. I believe what you're saying, because when I go to the community, this thing is rampant. So here's the Minister of Finance of Jamaica, one of our bigger countries, saying, the new Minister of Finance, going to his constituencies and saying, this thing is rampant. Now, I could convert that in statistics, but as he's going house to house, he's seeing it everywhere. Impoverishing people, sickening people. So maybe we need more ministers of finance to go to their constituencies in that sort of way. The idea of that high-level meeting is to really look at who's bearing the burden, what is the cost, and it's not just government. Social security organizations meeting in this hotel last week, Thursday, kicked into motion directors of Social Security and NCD task force. Why? The IMF issued a report, International Monetary Fund, about 18 months ago, no, 2 years ago now, just under 2 years ago, on the imminent insolvency of Caribbean Social Security organizations. How many people here live in the Caribbean, hope to retire to the Caribbean, are from the Caribbean? Does it concern you that your Social Security NIS is imminently insolvent? It does me. That they're going to put up the retirement age, change the contribution structures to deal with the arithmetic? The question is not being asked, can we bend the curve? Can we change this high level of payouts in the population for these preventable health problems? And the research is needed around that to analyze their claims, see what is eminently preventable, design, implement, monitor, evaluate, show the ROI, social impact investment type of approach. The private sector is bearing this burden. It's eating into their profits. Talk to Ed Clark, the Chief Financial Officer of Sagicor, on data that at a HCC conference a couple of years ago, he showed it and said, this is not good for business. But I don't have a mandate for preventing, he said. You do, you just don't have the money. So let's talk about how we get you the money to do the prevention. I like a business person who talks like that, because he understands we have solutions, but we don't have the money. So corporations are bearing this problem, families are bearing this problem, governments, and so that's who is bearing the cost. And then what are the investment needs and opportunities? Because it's not only pay. This, I just described one opportunity. In Haiti, we met the Association of Haitian Industries. And after an initial sort of hostile start, they said, how much money do you want? And we said, we want a partnership, not money. And they said, how much money do you want? What's the size of the check? But eventually we had a dialogue, and they described, yeah, there's a lot of untreated hypertension, diabetes. People drop dead on the shop floor. Somebody who's had an investment in them, because they're a mid-level supervisor now. So we discussed having a program that would focus on screening and education, and then you'd have to strengthen the facilities to receive people who are diagnosed. And then finally, in that sort of look, would be, where is the fiscal space? And our chair here would know that very, very well. Where do you find the fiscal space to make some of the investments that are needed? And it sometimes comes in unexpected places, certainly in the primary prevention. All our countries are doing things like some sort of transport or road upgrade. We need to advocate for biking lanes and walking paths. We have poverty reduction programs that are being restructured, revised with it. How do you infuse NCD prevention into that? And you can go on and on like that. Investments in agriculture and education. The Caribbean Development Bank regularly finances the revision of the curricula in CXC well, how about if we include more NCDs in health and the social and biology and all the other curricula? I see your side, sir. So those are my comments, and tying the data to the money and to development and wealth, and trying to make the case and explain where we're going next with engaging the finance and economy sectors of our region. Thank you.
Good morning, everyone. This morning's topic, sustainable health systems for economic growth, development, and wealth. Selena did a very good job in terms of describing the health situation in the Caribbean. And the health situation in St. Kitts is very similar to what she has described. Now, from a government perspective, Ministry of Health's perspective, the sustainability of our national health systems is very important in this context. The sustainability of any national health system is important to everyone, because as human beings, we all interact with the health systems at some time in our lives. And so I did a literature search, and there are really about 8 main factors that determine the sustainability of national health systems. And so I'm going to just describe these in the context of St. Kitts and Nevis to facilitate this discussion. All right, and so affordability, the financial state of the jurisdiction and the affordability of the health system. In St. Kitts, our GDP per capita rate for 2016 stood at about US 17,000. However, we ask ourselves, how much does our national health system cost the government? Well, in 2018, 10% of the national budget was allocated to health. And last year, about 9% was allocated to health. And then we look at that input versus the output. Our health indicators, are we totally satisfied with our health indicators? No, there is room for much improvement. The health system, as it exists, contributes much to the national economy because it helps to support a healthy workforce. But from where we sit, we realize that there is significant productivity loss due to premature deaths and disabilities from NCDs like the cardiovascular disease and complications of diabetes. Now, efficiency and effectiveness of the health care delivery. This is another factor that affects the sustainability of our health system. What are our interventions? Are our interventions effective and efficient? But when we look at our NCD problem, we realize that prevention and control of NCDs account for a big portion of our budgets. And if we continue along this path, would it be sustainable? Probably not. And so from where we sit, we have to change our strategies, shift focus to disease prevention and health promotion. We need to focus on our chronic disease self-management program, whereby we hope to develop a cohort of chronically ill patients who are engaged in managing their own diseases, because the literature tells us that chronically ill persons who are engaged in self-management, they have better health outcomes. And adaptability of the health system, that's another factor that determines sustainability. Health is dynamic, and our health system needs to be changing and be adaptable to these changes. There are changing demographics. At present, approximately 11% of our population are 60 years and over. There's a change in the epidemiological, there's an epidemiological shift in terms of the increase in NCDs, and there are new technologies. And so an adaptable health system is one that shifts and makes the relevant changes. In St. Kitts and Nevis, we realized that the number of patients with end-stage renal disease were increasing, and so in 2013, we started our hemodialysis unit. In terms of our cancer problem, in December 2016, we started our oncology unit, and last year, in response to the number of patients with mental illness, we started our mental health day treatment center. And in terms of health information systems, we are now focusing on rolling out our HIS system. And so in order for us to be sustainable, our health system has to be adaptable to the dynamic health changes. In terms of our healthcare workforce, we need to have a cadre of health professionals who are competent and skilled to meet the needs of our chronically ill patients. Healthcare delivery at present is very labor intensive, and an effective healthcare system must have the right number and right mix of health professionals. In St. Kitts and Nevis, our healthcare workforce stands at about 900. We recently did a situational analysis, and our human resource for health density per 10,000 pop stood at about 81 per 10,000. And this is quite good, because a density of about 44.5 per 10,000 pop is needed to support universal health coverage and to sustain the SDGs. And so a well-trained healthcare workforce is important for sustainability. Social determinants of health and the resilience of the population is also important. And so a government that's able to create and ensure healthy environments in our schools, homes, communities, workplaces, through relevant policies and legislation will promote good health for all. Addressing the social determinants will facilitate health system sustainability. Another factor that contributes to sustainability is that of contribution of external partners. Selena mentioned the global health financing, and as a small island state, we couldn't survive without the contributions from our local and external partners. For example, Caribbean Med Labs Foundation in Trinidad, PANCAP, CARPHA, PAHO, one of our primary partners, right? And so global financing through partnerships, very important for sustainability. The integration of policies and contributions from all of government sectors. And so taking a multi-sectorial approach is also very important for sustainability. And last but not least, political acceptability and support is important, and acceptability by the key stakeholders. And so, ladies and gentlemen, these are the main factors that facilitate sustainability of health systems. Thank you.
Good morning to you all. I am the economist on the team, and I sit listening. This morning it was interesting to hear the discussion on data, because we all know that if we don't have the data, it's very difficult for us to pursue the need we know we have to do. Having said that, given that the reality is that getting the data we need takes time, I just like to remind people, it's something that I think Sir George Allen says sometimes, that it's important that we do what we need to do to get the data that we need. But let us not believe that we must not do anything until we have all the data we need. We have to find ways of starting, responding with the data situation that we have. That is basic. It's important that as we do that, however, we do what we need to get the data going. So I just want to make that point because I live in the world where we just don't have all the data we need all the time. But I know that we still have to try to convince our leaders that certain steps have to be taken now. And I think we have to use whatever other kinds of information that we have to try to get that done. I think I just wanted to start with that point. I think on the sustainability question, it seems to me there are the aspect of sustainability that has always interested me with the health system is that when you look at all the countries of this region and you look at the health expenditure data, the trend tends to be is either an exponential trend or it's close to an exponential trend. What that means is that the rate of increase of health expenditure keeps increasing. If the expenditure increase 2% one year, and the next year it's increasing 4%, and the next year it's increasing 6%, and so on. That's one aspect of it that is slightly worrying. But you know what makes it more worrying is when you look at those rates of increase with the rate of increase of growth in the countries. And in every single country, the rate of increase of health expenditure exceeds the rate of increase of the income. Now, if you think about it, that is madness. That cannot continue because it is the national income that gives us the ability to spend on health. So if spending on health continues to go faster than the national, there's a day coming when we just will not have the resources. And that is the sustainability question. In that context, it seemed to me that three things, and I listened to Dr. Laws touch on a number of them, but there are three things that I thought that we should try to remember, keep in mind, if we want to deal with the sustainability. And the first thing is that the context is one where, as everybody knows, it is the non-communicable diseases that is really crippling us in the region. And it means then that the sustainability, that this is the disease set that is really causing the sustainability problem to get even worse. But when you think about it, you're talking about disease and disease conditions which are very largely preventable. And what that tells us is that, you know, maybe we have to go back to where we started 40 years ago. Because what the alma mater thing was telling us was that what we have to do is to change the way our health systems work. The health systems have to resound as primary care systems. That's what they have to do. They have to resound as systems that are looking to keep people healthy, as systems that are looking to manage people once they start to get to manage them well. And that focus of trying to change the health system is, I think, now we have to go back there, because if with these chronic diseases we don't do that, the sustainability thing will just keep getting worse and worse. So that's the first thing I think we have to do. But the second thing we have to know is that if we're talking about sustainability, then it has to be then that we also have to be thinking that, well, it means that the care that people need, people must be able to get the care. In other words, this access to care, that a few people already spoke about this one, access to care is something that we have to make sure that is really universal, also that this universal health coverage that we're talking about, this is not just a slogan or a slang. This is crucial if sustainability is important, because everybody, it says that everybody who needs care must get access it, must have access to good care. Now, except everybody has access to care, what is going to happen is that a number of people who should not be ill are going to be ill. So that universal health coverage has to be seen in the context of the sustainability that we're talking about. And the third thing I think, if it's sustainability we're interested in, is that we have to remember that as we provide care, we're using resources. And we're using resources that are scarce, resources that we want to do many more things with. It means then that there has to be, in our use of resources, there has to be a principle of resource conservation. You know what that principle is called? Efficiency. That is it. What it means is that, because one of the problems with us in health, is that we have been interested in doing things for people and helping people, but we have never been really too concerned about what it is costing us. That has to change. We have to decide that we're going about our business, but very concerned that this business called that wasting of resources must not be part of that. We have to deal with what causes waste. So that we have to make sure, for example, that what we're operating with are standards of care that everybody agrees on. There are protocols that everybody, so we will know in a predictable way what the cost of responding is going to be. But we also have to know that if we have, in today's world, you cannot have a health system in today's world that is not founded and based upon a proper health information system. Because it is the health information system which is going to tell us, it's going to help us to know how we're using our resources. That system tracks contacts between every contact between provider and patient. It's how resources are used. We know exactly how they, and we can know then, we can track the cost, and we can know when costs are getting out of hand very quickly. And the ability then the managers of the system have is to control costs in a way that they would never be able to control it if the health information system wasn't working. So that I am saying that the sustainability responding to it is not rocket science. And there are three things then that we need to do. The first is to remember what the health system was really meant to do for us. Keep us healthy. That is what it was meant to do. And that is where the primary care focus has to come back. The second thing we have to remember is that if we're going for sustainability, we have to commit ourselves that everybody who needs the care must get it. Universal health coverage. And the third thing we have to remember is that if we're providing care, we have to use the resources wisely and in a way that waste doesn't become the dominant factor. We have to use the resources in an efficient way. If we do these three things, I'm sure we are putting ourselves back on the track to become sustainable health systems. Thank you very much.
Since it's my second time up here, I'm not going to be very long. But I've got 3 points that I wanted to make that sort of take us a little bit away from the points that have been made earlier. I want you to think about 3 words: habit, implementation, and migration. And those seem to be so far away from one another, but stay with me for a second. I think what we're talking about fundamentally is change. We all need systems to change. We all need communities to change. We need families to change, and we need to be changing at the individual level. And so we need to think about all of these systems as systems of habit. And so even governments have habits, even economies have habits, and we need to really, if we think about it in those terms, how hard is it for us to change our habits? We all are sort of operating and behaving in systems and in environments where we probably are on autopilot half the time. And that's true for governments, that's true for economies, that's true for the way we interact with one another. And so I would challenge all of us to think about how to change these habits, and in particular about the notion of funding and financing and sustainability. We are here in this predicament because of our habits and the way that the entire sort of economic relationship, financial relationship within countries and among countries has habituated. The second thing is implementation. We focus within the GACD, we focus on implementation research. And so I would urge you as researchers to really think about that as a field of interest if you're not already doing it. It's a gap that we heard time and time again in the World Health Assembly this May. It's something that is identified as a priority for investment, and it's a recommendation that's being made in the NCD Global Action Plan. So I would really urge you to all think about the notion of implementation in the context of your research and your work. And the last point I want to make is around migration. If you take, how many people in this room live in a country other than the country they were born in? Yeah, me as well, my hand is up as well. If you put all of us together and make a country, we would be the 5th largest country in the world. Okay. Migrants, there are 244 million migrants in the world. Be the 5th largest country in the world. So I'm bringing this up to make a case for cross-national collaboration. It no longer makes sense to focus solely on our own individual countries. When we are moving, and we have moved, and we are citizens of the world, or we're at least citizens of the neighboring country. This is a part of our work, not just in terms of refugees and conflict migration, but just sort of your normal everyday migration. And these has impacts and implications not just on our health and our behavior, but also on finance and economics. And I think that's something that is missing largely from the debate and the discourse around funding and finance on NCDs. And just one last thing I would say is that the energy that it sort of is up here and also in this room, I think bodes well for the future of this region. And I hope to have the opportunity to bring folks back with me the next time I come to see and also to understand that this is a really good place to invest. Thanks.
I'd like to thank each and every one of the panelists for their contribution. I will make just a few comments and then followed with some questions framed in the context of research with regards to health systems, since this is a research conference. When you talk about health systems, we are looking at, in particular, the sustainable health systems. We are looking at more of the efficient and effective organization of people, institutions, and resources to be able to provide healthcare services to meet the healthcare needs of a particular population. And so Professor Theodore earlier, I think, hit the nail on the head with the first point. One, we still operate our health systems on a biomedical model of care. And we really have to make that shift towards people-centered, community-based, integrated healthcare services, tearing down the barriers, removing the fragmentations. Even though the HIV programs were successful, they were successful in the context of vertical programs. We don't need vertical programs for NCDs. We need to have more integrated programs if we really want to have sustainable healthcare systems. I'm not sure how much research has been done with regards to the model of care and the end point in looking at the value-based model of care. What is the value coming out of the system through the model of care? So if we can have a slight discussion on that, I don't know, James, maybe Professor Theodore will make a comment on, have we been doing enough research looking at the model of care, biomedical model, which was and is shifting towards the people-centered community-based model, which will really enable us to focus on NCDs like as a disease priority and also on ensuring sustainable health systems.
Prof?
No, I think that's an interesting question, because one of the things that always got me a little worried was that one of the big international agencies, I wouldn't call name, always used to be telling us that when we talk about reorienting the systems to primary care, they would say that you're saying that, but the data seems to be showing that primary care doesn't really save us money. I always found that very strange, because I thought if you set up a system where you look for early detection, and if you set up a system which is try to keep people healthy and lower the demand on the secondary and tertiary care, I could not see how that, but they claim that the data didn't seem to be showing. It turns out, if you go and check the data now, you'll see that over the last 5 years, there are a number of studies that are telling us quite categorically that focus on primary care makes good economic sense. What it's telling us is that as we do the integration that Dr. Ewing is, so as we do more of that health costs in the systems, the first thing you start to see is that the rate of increase of health costs becomes smaller and smaller. That's the first thing, and that so the picture I spoke about before, which was an exponential picture, it starts to get weaker and weaker. That's the first thing you see. And over a longer period, in fact, in some countries, they are telling you that the costs are actually coming out. So that, to me, there is growing evidence that moving in the direct, there is evidence now that it makes sense for us to focus on primary care. So as far as the research, there is research, in fact, that is supporting our point that, in fact, that moving to primary care makes a lot of sense.
Okay. James John.
Thanks, Rufus. Well, I think we need to be doing more, but if we take our 5 fishes and 2 loaves approach, since Selena started off biblically, in the 5 fishes and 2 loaves, when the 5,000 people were fed, the little boy had just a little bit, and he started, and then somehow it multiplied, and everybody got something. But when you look at what research there is, and some of the research that we're doing, and some which is in the conference, there's a lot of good papers, you begin to see things around cost and efficiency. So if you look at some of the work going on now on modeling the treatment cascades for care, if you use a tracer like diabetes, in our countries, the vast majority of people, 80 to 90% who have diabetes, have been diagnosed. They know it. But only 70% are maybe in any kind of care, 50% are on treatment, and maybe 20, 30% are under control. So that simple set of data then provides a lot of room for asking, well, why is that so? Those who have not yet been diagnosed, how do we get them in? And why, each of the drop-offs. Is it a use of guidelines? Is it the patients don't know? And what happens after that diagnosis? Why is there such a steep fall-off? I think part of the reason is people get this diagnosis and the doctor says you've got a touch of sugar or a touch of pressure, so you don't take it seriously. It's all new, you're confused, you've had a few minutes, and so it's very important that first month or so that the primary care system works to integrate that person into their new care regime. And the second one I'd mention is there are a lot of publicly available data on medicines in this region, and you realize if you look at the publicly available data that people are procuring at hugely varied rates. So just by looking within the region at the current medicines procurement, you can see savings. So the CARPHA has introduced the Caribbean Regulatory System for Pharmaceuticals, which recommends medicines for registration. And we're seeing in one of the countries where they procured 7 of those medicines, the prices are down. So you're getting quality and safety assured at better price. And when we get the volumes, we'll quantify the saving. There is a lot of scope for efficiency in our systems just with medicines. I wouldn't go on more, but I think I see that there's a lot of scope. Things like just putting amputations and kidney failure under surveillance, which for a couple of years data was collecting, and people said, but you have 40, you had 100 and something, and your population is only so and so. That's sort of basic, then stimulates, well, why is that so, and what can we do about it?
Thank you very much. Professor Theodore, you also mentioned a very important factor of efficiency. And in our systems, we note that there is lots of inefficiency where significant wastage in our systems. And from time to time, our politicians and our political directorates will point to that. And because of that, they look at healthcare expenditure from the cost perspective and wastage perspective, and they don't see the value of the investment that is put into healthcare. We want to reorientate the expenditure in health and put it more in the concept of an investment rather than it being an expenditure, because it truly is an investment, particularly when you shift towards the primary care model as opposed to the biomedical model. Looking at the wastage, in order to reduce wastage and to have more efficiency, I think our systems have another challenge, and that challenge as it relates to transparency and accountability of the use of the resources, and this also looking at the governance of the healthcare system. Because governance, in the governance framework and model of healthcare systems is a big issue, because one can argue that you can have the best primary care model being used, but it will still not work because the governance framework is not there to ensure the efficient and effective use of the resources. So any comments on that, and how much research can we do in that area of health systems governance looking at within our Caribbean region? I mean, Dr. Laws can comment, because I would look at, you know, we have a lot to do in regulating our health sectors. And within our health sectors in the Caribbean, there are lots of services and healthcare delivery services that are, by and large, unregulated, or the regulations are not strong enough. Because when you don't have a health sector that is not regulated, then the chances of adverse outcome or inefficient treatments and not using guidelines, etc., then you really do not achieve the value that you want to in the system. So all of these are issues with regards to us improving governance.
Well, thanks for highlighting one of the challenges that we are presently having in our own setting, that of regulations pertaining to our health practitioners, or more particularly our allied health practitioners, because we do have a medical act that speaks to physicians, nurses, dentists, etc. However, our allied health professionals, we need to tighten our regulations where this is concerned. And in terms of our health facilities, our laboratories, radiologicals, organizations, we need to tighten our registration requirements and regulations where this is concerned. And this speaks to standards of care to ensure that the quality of care that our patients receive is what it ought to be. And so that's important. I also wanted to make another point in terms of focusing on primary health care, just to add and underscore that the structure already exists, because in each of our jurisdictions there are health centers located in every nook and cranny of or islands, and the primary healthcare team already exists. And so I'm suggesting we need to just scale up the training of our primary healthcare practitioners to meet the needs of our chronically ill patients who are requiring complex chronic care.
Yeah. Yes, and I'm sure you mean not only the patients but persons, because we're not only looking from the disease perspective, we're looking at persons, being the center of our attention. Ms. Goro, and then I'll take a question from.
Just one challenge. You said that we should focus on primary care as opposed to biomedical model. If we really want to move away from the biomedical model, we should be talking about prevention. We should be talking about what we're eating. We should be talking about whether or not we can exercise and how much that is part of our daily life. And then you will truly see gains on your investments in healthcare, because people will not walk in the door in the first place. So I think that's, if we really want to push that out, then we need to be looking far beyond the clinics and sort of look at what's happening in the neighborhoods and in the homes.
Right, and that's why I just mentioned, you're not looking at patients. It's not a patient-centered model of care, but a people-centered model of care, because those are persons who are well that you want to remain well.
That's right.
Yes.
Good morning. So I work here, and I'm part of one of the offshore medical schools here. I'm the Associate Dean for Research. So I wanted to raise two topics that I think maybe were not discussed here. So one thing is the focus on local health delivery versus regional health delivery. So one of the things that I think we are missing here is centers of excellence that are regional rather than having them in each country on its own, because obviously the funds are not here. So we need to think a little bit more on opening regional centers. So that's one issue. The other thing is involvement of offshore medical schools in the health systems here. So I think we have more than 30 medical schools with professionals working in different islands, but we don't see much involvement of those medical schools in either the training or health delivery, or even in conference like this participation.
Okay, thank you. Thank you. Any questions on the floor for any of our panelists? Please.
Thank you.
Yes, and then rest after.
Crookshank, UK, Jamaica, but a migrant. I would like to ask what we're going to move on to discuss next. And by the way, Mr. Chairman, if you don't mind me speaking frankly, we've been listening to you all for a good while, but the people-oriented solutions comes partly from the floor. So I would like to ask Professor Theodore what he thinks about the real dilemma that's coming, and what you talk about of having a forward-looking view on the cost side of things. For ordinary people in the Caribbean health system, when I get my carcinoma of the prostate, or somebody nearby gets their cancer of the ovary, how, as the UK health expenditure system is facing at the moment, we're going to pay for £9,000 a month to keep their oncology treatment going. That is what part of the access to care issue is going to become for cancers. Can I put that dilemma to you as to how you're going to try and manage that? Because we're talking about inequality after this session.
Right.
I mean, within the region, that certainly is an inequality, Kennedy. Again, looking at publicly available data, one realizes there are some countries in the region, or blocks of countries, that are not even procuring certain essential cancer medicines because it's already too expensive. And what's needed is a convening of manufacturers and distributors across the region to talk about going beyond the individual small market to get a bulk approach, leverage the power procurement fund, etc. We really need to do that, because it's not coming. It's now that people are dying. And its standardized mortality ratio 2 to 9 times higher for several of the major cancers compared to North America. And so you realize we have a challenge, and that's part of it.
Question?
Yeah, Trevor Hassel, President of the Healthy Caribbean Coalition. So in God we trust, all others bring data. The question is the translation of the data into national policy. That's a big challenge. And then even as I say that, I take up the point that Kennedy has introduced, because that's the real challenge. So we've said primary care is what we should be aiming for. We've made the point that the cost of care is far exceeding national ability to afford that care. But even as we say that, Dr. Laws makes the point, and proudly so, that we have just introduced hemodialysis in the country. The reality is, as is true in so many other Caribbean countries, that it's really a significant challenge to maintain that service. And one will maintain it, quite frankly, at the cost of primary care. So the point I'm making here, and Kennedy has introduced this point, we need to address the issue of the cost of tertiary care. That's really a challenge that we're not addressing at all in the Caribbean. How are we going to address that issue? Because that's where we're expending a significant amount of our resources. And I'm not sure how we're going to address that in these very resource-limited Caribbean countries.
Okay. Thank you. We will have Dr. Fredericks and Dr. Frankson. I'm not sure we can have enough time for the last question, but.
Okay. Thank you, Chair. I'll try to be brief because I think most of it has already been said. But I'd just like to follow on from Prof. Hassel. And as a CMO, I know it's a challenge because we have primary care, and I do believe that primary care is the way we should go. And we need to promote what we have in primary care more. I think many persons don't even know of the services that we offer, most of the times relatively free for primary care. But we also right now have a significant burden of persons who need secondary and tertiary care. And you can't totally ignore them. Of course, there's the political aspect. But, I mean, they are relatives, they are us, you know? So I do agree that we need to find that balance, but, and definitely promote primary care. I see Dr. Radix in the audience, head of the OECS Help Desk. And for the OECS, when we think of the pool procurement system we have for purchase of pharmaceuticals, Mr. Burnett is probably around as well. That's another way that we need to go. We need to do things together when we're talking about sustainability. It's cheaper if we come together as a group and buy meds and maybe lab reagents and other components, maybe even servicing our equipment, monitoring and managing our electronic systems that we've been putting in. Instead of having little units in every country, why can't we at regional level, be it OECS, be it CARICOM, be it CARPHA, have some kind of a pooled mechanism where you can have a group of professionals or, you know, persons who can move from country to country and provide that service. I think we also, CARPHA does it in terms of M&E, you know? So I think these are some of the things we need to do. Let's do it together. Let's pool and buy in bulk rather than going individually as many teeny weeny little countries. Sustainability of health, and I think it came, I think I heard Selena and some others mention it. Yes, we need to focus on the health sector, but remember the social determinants, right? Yeah. So we need to support investments in education, investments in food, in clean air, because when persons live in a healthy environment, they'll be healthier and they will have less diseases. So when they come to us or when they come to the health sector, the cost won't be so high. And in terms of research, I know about the collaborative research that's been promoted, and I think a lot of it is already going on, maybe more in terms of UE and CARPHA, etc. But what about research between health and non-health sectors, totally non-health sectors? Is that being supported as well? Thanks.
Thank you. Dr. Frankson?
Tony Frankson, University of the West Indies, based in Bahamas. And had the pleasure of working with Dr. Ewing in Turks and Caicos in 2004 to 2006, where we wrestled over some of these very same issues. Just a little philosophical question, and I hope it's not rhetorical. What do you mean by primary care? Because most of the times when we go and talk about primary care, I realize that even when you make it people-centered, Rufus, they're really talking about primary medical care. And I get very frustrated with that because the reality is I've lived through situations where governments have talked about bringing in a universal health coverage and that they will emphasize primary care. And when they brought it to the grassroots, they were still relying mostly on the physicians. They had not tapped into the richness of especially Alma Ata's highly neglected component, community involvement. And they much less to tap into asking environmental health to do more than control infectious diseases and so on, but to show environmental health that they can have a new lease on life, complementing the safety of the things that you must do to prevent the chronic non-communicable diseases. And not just prevent them, but move towards a model of wellness. And I am very, very troubled that if we keep on that model, the exponential model may just dent a little bit, but it will still be exponential. I'm also aware that Sir Jeffrey Rose was the one who reminded us that the moment you start to help people to get healthy, they're now living longer, and because of that, they are going to send up your expenses. So what you need to do is to, as you said, look at it as an investment and really take it seriously as an investment and get these people not just staying healthy longer, but also staying more productive and profitable to the society longer.
Productive,
I rest my case on that.
Thank you. If you have a question or comment, it must be very short because we're running out of time and we have to move on to the next session. Thank you.
Well, thank you. I looked behind me and the person sat down. I just want to go back to Prof. Theodore's issue about going back to primary health care. I think that's the way to go. But way back in medical school, we used to say the alma mater motto was health for all by the year 2000. We are now to 2018. It means it hasn't worked the way it was meant to work. And therefore, we need to not go back to the primary health care as we see it, but a reinvigorated primary health care, whereby someone may not be ill, but go to a polyclinic and immediately within 10 minutes, 30 minutes, have a blood pressure checked for him. If you go to any clinic, most of our clinics, and you want simple screening done, it might take you 4 hours, and they're not going to come back. Someone talked about environmental health officers, reinvigorated environmental health officers. My mother used to fear the environmental health officers more than the police. But these days, they are powerless. So I think we need to go back to the primary health care, but there has to be a different primary health care.
Thank you very much. And a big round of applause for all of our panelists and you, the audience. Thank you.
Very good. Yes, thank you all. We have some announcements. The first one is that we have run a bit over time, so the break will be 30 minutes instead of 45 minutes. And there are 3 coffee break stations, 2 in this room and 1 in the Antigua room, which is directly opposite. The opening ceremony this evening will be held at the Royal St. Kitts Hotel and starts promptly at 6:30 p.m. All registered delegates are invited. And then presenters for the next session are asked to visit the projection desks at least 20 minutes before the session starts to complete the presenter's information card. Delegates who are interested in continuing medical education credits should visit the CARPHA booth and sign up every day for these credits. And please be reminded to fill out your daily evaluation forms using the electronic boxes in the foyer. And for those of you who want Wi-Fi, the network is Marriott _.